All right, so I'm going to try and make this video larger. So post-operative care, I cut out a couple slides and then I'm going to talk about some quickly because they don't really pertain to what we're going to do. So as I mentioned in the perioperative care, the perioperative area begins when the patient schedules their surgery, and the post-operative period ends when the patient is discharged from their surgical provider. So the patient's recovery is handled in the PACU, the post-anesthesia care unit, and this is handled by the anesthesiologist and the recovery room nurses. It can also be handled by the certified registered nurse anesthetist, and this is a master's prepared nurse who has gone through additional schooling, 3 years, and the patient has received general anesthesia, and remember, general anesthesia is given to create a state of unconsciousness, and also the patients need respiratory support. So once the patient needs respiratory support, then their assessment in the recovery room is going to need to be monitored for respiratory complications. So the postoperative period begins immediately after surgery, and the recovery room is often located directly to the OR, and that way there's immediate access to anesthesia and operating room personnel in the event that something happens. And nursing care focuses on protecting the patient and preventing any complications. And the primary goal is for the patient to recover and have minimal anesthesia complications, such as needing to be re-intubated. Intubated meaning having the tube put in their throat. I think if I do this, then it affects your screen, so I need to go back to this way. And then that way you can see it better. How's that? You can't tell me because it's recorded. So the initial recovery period, immediately they are watched. There's 2 phases, phase 1 and 2. And phase 1 is when the patient is still under a lot of the anesthesia. Usually they're reversed, or the anesthesia is starting to wear off in this phase. And the patient is very closely guarded, depending upon also on the type of surgery they had. And then the patient is transitioned to phase 2. There's no visitors to the PACU area until the patient has progressed to phase 2 and further on. So in this area, when a patient is being in phase 1, we have extra airways. There's a ventilator, lots of oxygen, everything to hook up for vital signs. They're placed on an EKG monitor, and we can monitor invasive lines, and there's lots of medications, and a lot of times anesthesia can create hypo or hyperthermia. So it just depends upon the patient's reactions. Remember, if the patient was going to have malignant hyperthermia, it would happen in the OR. It would not happen in the recovery room at this phase. So the OR will give the PACU report, the type of surgery that was done, and then anesthesia will tell them what type of anesthesia medications they had. And then intraoperative management will be how much blood loss, fluid replacement, urine output, and then any unexpected events, the trends of their vital signs, and then if they ran any labs in surgery. Post-operative assessment, obviously first, we're going to do our ABCs. So we're going to do airway. Usually the patient is extubated, meaning we remove that airway in the operating room, and that is done by the anesthesiologist before the patient is brought to the recovery room. And then we are going to do breathing. What is the respiratory rate and the quality? What are their breath sounds? Do they need extra oxygen? At this phase, yes, because they are not wide awake yet. Circulation, what does their EKG monitor show? What are their vital signs? What are their pulses, cap refill, skin color, and temperature? Obviously, we expect them to be cold. The OR was cold, so we expect them to not have a normal temperature at this point. Neuro, are they awake, alert? Obviously, at this point, we don't expect them to be awake and alert yet until they are later in phase 1. And because they're receiving paralytics, what do you expect their pupil size to be? Probably pinpoint. And then can they feel us, depending upon the type of surgery they had? and GIGU. Remember, anesthesia affects the ability to pee. So if they had a catheter, how long after they had that catheter removed do they have to pee? 8 hours. Hearing is the first sense to return. So we want to explain to them everything that we're doing to them, okay? And then GI, assess their bowel sounds. Remember, if they had a GI surgery, anesthesia, and everything has stopped, so they're probably not going to have bowel sounds in the OR, or in the PACU, I mean. And if they have an NG, we need to verify placement. Even if they put it in surgery and they saw it in the stomach, you don't know if when they move the patient over, so you always have to verify that. Don't take someone else's word for it. Is the patient having nausea post-op? Treat them with nausea. Everything is available. The anesthesiologist is available at this point, and we want to be able to treat them and give them the medications to make them comfortable. Surgical site, what is the surgical site? What does the dressing look like? Is there any drainage there? Pain, is it incisional? And then what are the labs? Do we have a slew of labs? All right, moving into post-operative complications. The big one is airway obstruction. So we want to assess for hypoxemia and atelectasis, any aspiration or bronchospasm, and hypoventilation. So we always want to make sure when the patient is coming out of anesthesia that they are placed into the lateral recovery position. And with this, the patient is placed on their left side, and the tongue is moved out of the airway. And then that way it allows them to have maximum expansion of the thorax, of the lungs, as well as there is no potential for airway obstruction. Once patients start to wake up, their first natural instinct is to roll over on their back. So if a patient rolls over on their back and they can't breathe and their oxygen sat starts to drop, what's one of the first things you want to check? Airway. What's one of the things you're going to do? Reposition that airway. Go back to CPR. How do we adjust an obstructed airway? The jaw thrust position. Okay, so that is back in basic CPR. That is healthcare CPR 101. That's repositioning the head, the jaw thrust position. Then to prevent those complications, we're going to give them oxygen therapy once they wake up more. Teach them cough and deep breathing. We want them to change positions every 1 to 2 hours. Get them up and get moving. Give them early fluids and chest CPT if they need it, if they are holding on to secretions. That's kind of like we beat on their chest. And adequate pain management. Remember, the more we treat their pain, the more likely they are to cough and deep breathe and get up and move. So this is the splinting technique that we talked about. Cardiovascular post-op complications, hypotension, they haven't been eating and drinking. So we can have decreased perfusion to the lungs with hypotension. Decreased perfusion to the vital organs. So we want to make sure that they don't have any disorientation. So mental status, what's their level of consciousness? Do they have any chest pain? Did their kidneys take a hit? What's their urinary output? Most often, hypotension is going to occur in the recovery room first. You may see this up on the floor initially, like post-op day number 1. Cardiac, you might see some dysrhythmias. We want to make sure that those are addressed right away. Hypertension, those we usually see because the patient's in pain. And so how are we going to treat that? We're going to give them pain medication. Blood clots, because the patient is not up and moving and they've had venous stasis. Syncope, this is usually related to decreased cardiac output, and they have tried to get up too quickly when they've gone up to the floor or post-operatively when they're ready to be discharged home. So fluid overload, post-operative complications. Fluid retention can result from the stress response and having increased secretion of the ADH. And so the body is holding on to more fluid. We can have a fluid deficit. So we didn't treat their dehydration. So someone, say, who was going for a hysterectomy and they just gave them regular IV fluids in the OR, and they didn't treat them for the bowel prep that they had, and they lost too much fluid. And with that, they're going to have some electrolyte imbalances and maybe some potential acid-base imbalances as well. They could have some hypokalemia. So we really need to make sure that they got a good history as well. Nursing interventions to prevent cardiovascular complications. Usually in the early phases of recovery, vital signs are taken very frequently, every 5 minutes to 15 minutes. And we're going to notify the physician or the anesthesiologist if the systolic is less than 90 or greater than 160, and if our pulse rate is less than 60 or greater than 120. If the vital signs are within those normal limits, we're just going to monitor them. We're just going to continue to monitor them, document them, and move on. So remember your normal vital signs. If they're within normal limits, we're just going to keep monitoring the patient. Back to this slide, if the patient is got a low blood pressure, then we might want to check their I&O, and then otherwise we also want to check our surgical site as well, see if there's any bleeding. So I&O, and then we're going to check all of these lab values. We're going to check potassium, BUN, creatinine. And then we're going to check a magnesium, because remember, cardiac-wise, potassium and magnesium go together. BUN, creatinine, what's our fluid status? What is my kidneys function? And hemoglobin and hematocrit. Did we have an excessive blood loss? So neurological, cardiovascular. Early ambulation, get them up and moving, especially when they're out on the floor. VTE prophylaxis, they might be getting low molecular weight heparin. And again, we want to monitor them for orthostatic blood pressures with increasing in mobility. So slow changes in body position. We don't want them to get up and jump right out of bed and start walking. We want them to slowly change body positions. Sit it and dangle at the side of the bed for a little bit first. And if that was too difficult, then we're going to put them back in bed for an hour and try again later and move on. So neurological. When they're coming out of anesthesia, they can be a little bit confused. They can have some anxiety. And sometimes the pain medications we give them in the operating room can cause some of this confusion, etc. And by the time they get up to the floor or they are discharged, all of this usually goes away. Sometimes those silent alcoholics who don't report how much they drink, going through some of these medications actually can put them into alcohol withdrawal because they haven't drank in 24 hours. So recovery room will give you what their baseline was, and then obviously these patients are going to be admitted to be watched. So again, what is the number one sign of hypoxia? Confusion. So if a patient's starting to become confused, we're going to check our pulse oximetry. Maybe they need some oxygen. So monitor our pulse oximetry, give them some oxygen therapy, pain management, and if we have to, we're going to do some more reversing agents, and then we may have to institute some alcohol withdrawal protocols. So again, we might have to check fluid and electrolyte balances. Did they have good sleep? And then again, neurologically, depending upon the type of surgery they had, do they have bowel and bladder functioning? And also from the anesthesia aspect of it. And then can they ambulate, and what's their activity level? Are they going to be able to return to take care of themselves? Remember, patients who had general anesthesia cannot drive themselves home after surgery. Someone must be able to take them home, and they should not stay by themselves for the first 24 hours. Again, pain and discomfort. Remember, we talked a lot about pain and discomfort and what it can do physically and psychologically for a patient. And so they can have pain medications, oral, IV. We try not to do IM. We can do epidural catheters. We can do the PCAs, the patient-controlled analgesia. Remember, it is patient-controlled. Hypothermia and shivering. Again, remember the OR is cold. Shivering can increase our oxygen use. So we may end up having to draw some ABGs because we want to make sure that the patient's oxygen saturation is staying. So we do some passive warming, such as giving them blankets. We can do active warming, where we give them forced air warmers. And we can do humidified warmed oxygen. Oxygen therapy we give to to counteract the increased oxygen demand from shivering. We do meticulous asepsis. So everything is, we wash our hands and do everything when we're maintaining the surgical incision in the IV site. And again, turn, coughing, and deep breathing. And this is in the initial recovery room phase and as well as on the floor. GI, obviously some patients are going to have postoperative nausea and vomiting. And it can happen in the recovery room, or it can happen up on the floor or when they go home. It's the most common complication that leads to increased hospital length of stay. They can have increased abdominal distension due to delayed moving, aka peristalsis, and they can get an ileus. An ileus is a blockage in the intestines, and that could be because of their bowel being stressed. And if they've had a major abdominal surgery, this is one of the major things. Let's see. Other things, so if they have nausea and vomiting, we give them antiemetics, prokinetics to help GI motility. We can give them an NG tube if they have an ileus. Give them adequate hydration, so IV fluids. Assess their bowel sounds. If they are complaining of gas pains, not being able to move, etc., we can get them up and walk them. If they're complaining of gas pains, get them up and walk them. What happens every time you take your dog for a walk? They poop. Get your patient up, have them walk around and move. So get them up and move them. Early mobilization. That's what we believe in. Let's see. Urinary, we've talked a lot about this. We've talked a lot about catheter-associated UTI. We don't keep those catheters in. Let's see, what else? They can have urinary retention, frequency, decreased urine output. Nursing interventions, we can monitor urine output. We can have adequate hydration. We want to remove the urinary catheter when it's no longer needed. Normal positioning for elimination. Have them get up and go. Laying flat in a bed and going on a bedpan doesn't work. We do the bladder scan, the ultrasound of the bladder, to see how much urine they actually have in there. Next, surgical site infection. Monitor that surgical site. Do they have a blood clot there? What do the wounds look like? We're going to adequately look at those. Assess the wound. We're looking at drainage, color, consistency. On this exam, there's not a ton of questions. There might be one related to surgical site infection, but I don't remember a lot on surgical site infection. So how do they get out of the recovery room? They go from phase 1 to phase 2, and fast tracking, the patients are recovered actually in the operating room, and then they go directly to phase 2. And this I deleted, but it obviously didn't save. So how are they discharged from phase 1? They're pretty much stable. And then they move on to the next phase. Most places, the same recovery room nurse keeps them and then just recovers them, and then they pick up another patient. So discharge report to the nurse on the floor is situation, background assessment, and recommendations. You know this well. Phase 2 can occur in the inpatient setting in the hospital or the ICU. A lot of patients just go directly from the OR to the ICU and they're recovered there. Nursing care focus for phase 2. I guess they're calling phase 2 being recovered, the extension of recovery on the floor. I take that back. And extended observation. So what happens on the floor? We just want to be able to assess these patients as we would typically. The patients still get frequent vital signs when they get on the floor. That's one of the first things we want to do when that patient hits the floor is take vital signs. We want to make sure that their vital signs are stable. And vital signs are usually Q15 times 4, Q30 times 2, and Q1 hour times 4, and then you follow the guidelines. How do these patients go home if they're in an ambulatory surgery center? They must be alert and orientated. Again, they can't drive. They don't take any IV pain medication for 30 minutes. And then they get written discharge instructions. Again, great instructions. The better you teach these patients about their medications and discharge instructions, the happier they are and the less complications that they have. Let's see. And when to tell their physician if they have an infection. We want them to call their physician if they have a fever greater than 100. This is different than at the hospital when we tell them that if they have a fever greater than 101.5 is when we do that. Because they're at home, they're in a community setting, we want them to call the physician if they have a fever greater than 100. Again, this is not a gold standard. In our area, most physicians will say 100.5. So it's physician, surgeon specific. And then discharge home is when they are no longer meeting hospital admission criteria. And the elderly patients, they have decreased respiratory function. So their lungs are not able to expand like they should. Their blood pressure is not as stable as what it used to be. Their glomerular filtration rate is higher, so they don't process drugs like they used to. Drugs can have a different change on their mental status. Pain control is a myth. As you get older, you do not have an increased pain control. Your pain control is essentially the same as you were, no matter how old you are. So that is a myth that the elderly have a increased pain control, but the elderly are more apt to not want to take pain medication because 1, it will affect their bowels, and 2, they have a higher feeling that they're going to become addicted. So educate, educate, educate. This is your updated, abbreviated post-operative thing, and we will talk about this in the morning. If you have any questions, please feel free to text me.